For nearly a decade, the global health community relied on the Ervebo vaccine as a high-efficacy defense. It had successfully contained several outbreaks of the Zaire strain, the virus responsible for the most lethal epidemics in recent history. That confidence shattered in May 2026. The World Health Organization officially declared a public health emergency of international concern, its highest level of global alarm. The data was immediate and severe. Over 900 suspected cases and more than 200 deaths were reported across the Democratic Republic of the Congo and Uganda in a matter of weeks. The medical safety net the world presumed was in place had failed. The rapid expansion of the virus forced the global health infrastructure into an unplanned crisis response. Microscopic analysis revealed a critical problem. The 2026 outbreak is caused by the rare Bundibugyo strain, a variant with a molecular structure distinct from the Zaire strain that global stockpiles were built to fight. Vaccines rely on precise molecular recognition. The Ervebo vaccine was designed to target specific proteins on the Zaire virus, but it cannot bind to the unique surface markers of the Bundibugyo strain. This means the existing vaccine does not trigger an immune response. Because of this biological mismatch, there are currently no approved vaccines and no approved therapeutics available for clinical use against this specific strain. Medical teams lack a proven toolkit. Research labs restart from the beginning, while the infection actively spreads outward. The first infections were traced back to April 24th in Ituri Province, DRC. A nurse in a rural clinic showed classic symptoms, but the initial diagnosis failed to identify the specific strain. A critical 3-week gap followed. During those 21 days, the virus moved through the community without any formal public health intervention or containment measures. Containment was nearly impossible. Ituri is a conflict zone where mobile armed groups physically block medical personnel and contact tracers from accessing the very areas where the virus is most active. The humanitarian impact was immediate. By the time response teams could bypass the blockades, many victims had already died in their homes without ever reaching a specialized treatment center. In a fractured conflict zone, a delayed response acts as an accelerant. A localized medical incident was allowed the time and space to evolve into a regional health crisis. The virus eventually escaped the rural zones and crossed international borders. 2 laboratory-confirmed cases appeared in Kampala, the densely populated capital of Uganda. The most concerning detail for health officials was that these 2 urban cases had no apparent epidemiological link to each other, a strong indicator of undetected transmission within the city. The international response was a wave of localized panic. Nations including India, the US, and the EU immediately implemented aggressive travel bans, mandatory 21-day tracking protocols, and strict symptom screenings at all points of entry. These unilateral border closures were enacted despite explicit advice from the WHO. The organization warned that trade and travel restrictions often lack a scientific basis and actually hinder response operations by complicating logistics. When biological defenses fail, governments default to geopolitical lockdowns. These blunt measures fragment the international cooperation required to manage a spreading pathogen. An uncontained outbreak is an economic event. Before a virus physically reaches a foreign shore, financial and logistical impacts are felt across the global market. $22 billion in annual trade moves between India, the US, and sub-Saharan Africa, including essential pharmaceuticals. But risk triggers a market fear multiplier. Freight operators add surcharges, insurers review profiles, and banks freeze letters of credit. Trade routes shut down on perceived risk alone. Exporters also discovered a significant financial gap. Most standard business interruption insurance policies explicitly exclude losses caused by epidemic events. This economics of fear paralyzes supply chains. The financial damage is often more widespread and difficult to recover from than the biological threat itself. This regional paralysis and global panic stands in direct contrast to the pandemic preparedness pledges made during recent G20 summits. The 2026 Bundibugyo outbreak serves as a direct trial of those commitments. It measures whether diplomatic words can mobilize medical supplies, maintain trade corridors, and coordinate laboratory efforts during an active crisis. Global safety demands a system capable of rapid logistical and economic adaptation. When one link fails, the entire mechanism can freeze.